Good evening, everyone. Thank you for joining tonight's webinar. I'm Caroline Bice from the Workforce Development Team at Murray PHN. I begin by acknowledging the traditional owners of the land on which we work and live. We recognise, celebrate and respect Aboriginal and Torres Strait Islander people as the first Australians. We acknowledge their unique cultural and spiritual relationships to the land and waters as we strive for healing, equality and safety in healthcare. We pay our respects to their elders past, present and emerging and extend that respect to all First Nations peoples. The presentation delivered tonight is for information purposes only and does not take into account individual circumstances. Practitioners will need to make their own professional judgment on a case-by-case basis. I'd now like to introduce our presenter for this evening, Dr. Peter Eizenberg. Peter is a Director of Doctors of Ivanhoe, a member of the AUSVAC Safety Advisory Committee at NCIRS, a member of the Immunisation Coalition Scientific Advisory Committee, and a member of the Influenza Specialist Group. I will now hand over to Dr. Eizenberg. Thank you.
Thanks so much, Carolyn, for that kind introduction, and welcome everybody again to this next segment of update for all things immunisation. So, as usual, lots happening and lots to get through tonight. Customary for a speaker declaration, just to confirm that whilst I'm a member of a number of those committees, I have no financial gain from any company and receive no payments or have shares in any vaccine company or other. And my payments are on time basis, and the views that I expressed tonight are not necessarily representative of any of those organisations. So here's our task for tonight, is to get our teeth into and take a deep dive into these topics that I think are of particular relevance for all of us vaccine providers, challenged with yet another change in the last 24 hours to include the free extension of a free vaccine program for flu, and how do we manage that smoothly in our practice. We'll cover that in detail together with the COVID update, co-administration of COVID vaccines with other vaccines, and managing all the multiple vaccines we have in general practice, as well as a safety update, a presentation of the AUSVAC safety data to date, and then a shingles update with some changes that have occurred in the last few weeks. So the references as usual, the TGA and ATAGI guidelines guide us for all of our clinical practice. ATAGI sets a clinical guidance on all the vaccines that are licensed by the TGA, and the Australian Government Department of Health provides the national COVID-19 vaccine rollout strategy and the other national immunisation programs, and state-based supplies elements of that delivery. And the NCIRS, that's the National Centre for Immunisation Research and Surveillance, provides very helpful education as well as research, and we'll be looking at some guides from them. AUSVAC Safety is the National Vaccine Safety Monitoring Program, and the Immunisation Coalition is a collaboration of government, industry and providers, vaccine providers, organisations and all that represent them. And of course there's the reference of the Definitive Australian Immunisation Handbook, which is what we should always refer to. The specific references for tonight's presentation will be circulated to you after the talk, so that you don't need to write too much down. All of it will be contained in the references, but I'll be helping you to pick the eyes and manage all of the vast resources that we're provided with. So let's first get into COVID-19 vaccine update, and you'll be familiar with my format of reminding you of all of the fact sheets and guides that exist and are updated on the website. And it's good to see that the latest updates are now chronologically dated, so that we can track the ones that we've seen and the ones that are new to us, so that we can then hone in on them. That's just a snapshot at the top of a long list of updates updates. Naturally, the COVID-19 vaccination training program is essential for all personnel involved in handling and managing COVID-19 vaccines, and that program continues to be updated with changes and new information and new resources. And it is an extremely valuable resource in itself because its comprehensiveness and its handy layout and to assist us all in delivering is a reference point that you can go back to. Naturally, Murray PHN provides the health pathways in collaboration with all the other PHNs, and this resource as clinical guide for us locally in the area that we're in, me in Melbourne, you up in Murray PHN area, and you can see where guidelines vary with local hospitals and resource bases and authorities, and for your local guidance for clinical management. That's an excellent resource. And the COVID-19 resource list for Murray, as with all other PHNs, is extensive, comprehensive, and clinically guided. So please make use of them. Just a quick snapshot through where we're at with COVID. We've been looking at this in each of the formats for those of you who've attended before, and for those new, we get an update of perspective of where we're at. So we've had in total cases of Australia for COVID-19 to date over 7 million cases, with the death rate of 8,000 total deaths over that time. And if we have a look at the number of reported cases over on this side, you can see that our earlier waves, hard to make out there, they're just little blips, hardly visible, compared to what we're seeing in the last 6 months of enormous increase in numbers with the Christmas, New Year, the spike, and ongoing very, very high numbers, even compared to other countries in the world. This is high in terms of circulating cases. In a sense, it's good in that it comes at a time where we're mostly vaccinated. We have a high, mature level of vaccination. So we were hoping that if and when this does occur in our country, that it occurs at a time where we're largely protected. So that's reassuring, but when we have a look at the numbers here of the current cases in ICU, hospitalisation, we see that these are bordering on overwhelming our health resources. And when we combine that with what we're seeing with flu outbreaks now, that's exactly what's happening. So this is reassuring that we're not seeing the level of rates of death that we have observed in other countries. We are seeing numbers of too large for us to comfortably handle. The other important perspective is the cases by age group, and we can see that the majority of cases, as it has been right from the beginning, have been in younger adults, and compared with the case burden for deaths and severe outcome and disease, disproportionately high. So these very small relative numbers of people who are elderly have a very high disproportionate death rate, and age is one of the most significant poor predictors for outcome and highest rate of severe outcome. So that's that chart, just having a look at the case numbers and the cumulative cases displayed on the different scale. So the new cases in blue and the yellow showing cumulative numbers of cases. And you see that it's in the last 6 months that cases have soared and continue to do so. We talked about that just before, emphasising majority of case burden disease numbers is here, but these are the age groups that suffer the worst. When we look at the average daily PCR tests that are conducted in all jurisdictions, looking back over the last time period on here, which is going back into September last year, and we can see the numbers of tests are being done very high level. The caseload is proportional to that, but the scale is different. So these dots here are the average daily cases. And so we're seeing we're now around something like 50,000 cases a day being diagnosed on a background of about 200,000 to 300,000 PCR tests being done. There's a whole lot more rapid antigen tests that are not represented on this slide. And so the meaningfulness of all these figures becomes lost if you try to see more into it than you can. But the trend is certainly crystal clear. In looking at comparing active cases, which is this dotted line here, on a scale of shown over here. So this scale, this is touching 1 million cases, and this is the yellow and the blue represents ICU admissions and hospitalizations on this scale, which is 1,000 times less than what this scale is. So we get a clear perspective here that whilst the pattern of hospitalizations and ICU admissions follow the pattern of cases naturally, the scale is very much different. So the majority of cases, that is an individual person's risk, is very small of having a severe outcome, but the sheer numbers of people who are getting infected with Omicron being so much more infectious than previous strains means that we are still overwhelming our resources. Looking at the daily view of deaths, we have still a very worrying number of deaths on a daily basis in Australia. And the cumulative death rate, particularly in the last 6 months, is climbing, and we don't see an end to that. So that's the background to our vaccine rollout program, and with a update in the last few days showing that we've given a total in Australia of almost 60 million doses of COVID vaccine since the beginning of the program. At least 20 million people have had 1 dose or more, and almost 20 million are fully vaccinated, of having, by the definition of fully vaccinated, more than 2 doses. But those who've received 3 or more are also increasing, but at a fairly slower rate than we'd like. So we want to remind people of the importance, particularly for Omicron, and particularly those who've had 2 doses, their second dose a while ago, that we really need to focus on those who have need for 3rd dose and those who are eligible for the 4th dose, which we'll define in a minute. Booster vaccinations, we see that there's 53% of people who've had a 3rd dose or more. And in aged care residents, we are seeing a very healthy, over 90%, that is, vaccination rate of people with 3 or more doses. We also see that the winter 4th dose for people who were eligible, and it was recently expanded, we'll talk about that in a moment, there's a very good number of people with a daily increase of people who have had their 4th doses. The milestone charts are always handy to look at in terms of the movement of number of doses administered per week. And on this chart, it demonstrates which vaccines. And we see earlier in the program, our vaccine program got off to a kickstart with the AstraZeneca vaccine, but by far and away, as Pfizer dose availability has become more available, and the relevance of Pfizer providing a different level of protection against Omicron, we see the predominance there. And we're seeing creeping up here Moderna in the darker grey, or it's really a light grey on my screen, numbers starting to become significant, but Novavax is barely represented in terms of numbers of doses given compared to the vast majority of the other brands. Hard to see these slides, but just to remind you that the data is there. If you want to have a breakdown of the different doses across the age groups, and how that's distributed. And of course, very important to see that we're getting improvement all the time in the number of Indigenous people who are receiving vaccine in Australia. So we're now up to 85% of people, of Indigenous people over the age of 16 have had at least one dose, and 80% fully vaccinated. And but the important area that is really slower than we'd like to see is in number of Indigenous children who are eligible for vaccination is really not as high as we'd like. So if we look at this slide, demonstrates the potential of age group of people who are eligible for vaccination, and they are represented in this grey shadow here. So one dose only in blue, received a second dose, by the definition of this as being fully vaccinated. But these are the number of people in age 5 to 11 who are yet to be vaccinated. We see at the other end, the older age end of the spectrum for Indigenous people, a healthy high level of protection. So we really need to focus on catching up children in Indigenous areas. So it is important for us to keep our mind on the other side of safety with COVID vaccine safety. So throughout the talk, I will be giving you snippets of the AUSVAC safety relevant to the topic that we're talking about. So as of just a couple of weeks ago, the vaccine safety data for COVID-19 vaccines, remember I said that there were about 60 million doses that have been given. Well, 6 million, that's 10% of actually of people being given a COVID vaccine in Australia have actually participated in the AUSVAC safety vaccine surveys. And that is an amazingly highly robust level of participation to get meaningful data of what the true safety is. We learn safety from the clinical trials, but that's on thousands of people, not millions. And here we have on millions of people safety data. We can break down, when you go into the AUSVAC safety website to have a look, you can select the different vaccines by their brand. And of course, other vaccines we'll come to later on in the talk. And the latest COVID-19 safety data can be examined for all participants, all broken down by age or by a particular risk category that may be of interest. You get a display when you click on that. This is the adult doses given. So in total, here are the numbers given, say, just for Pfizer. So we're just looking at Pfizer vaccines given as of that date from the beginning of the program. And you get the numbers that are given for each of dose 1, 2, and 3. And you get a pie graph demonstrating how many people reported at least one adverse event. When they were sent surveys for COVID, there were 3 surveys, day 3, day 8, and day 42, asking them if they had any reaction. And these are the percentages that have been that are showing reactions. So for Pfizer, a little bit more reaction dose 2 compared to dose 1, similar for dose 3. Furthermore, the information provided in these reports shows the nature of the commonly reported adverse event and the relative proportion, also broken down by dose 1, 2, and 3, so that you get a feel of how many people get local reactions, what percentage of people get tiredness, headache, muscle aches, gastrointestinal, or fever. And that's a very handy display for discussing with patients what to expect. The severity is indicated by how many of those people that reported reactions needed medical attendance for it, either to see their doctor or to attend emergency department or to get medical care. And very pleasingly, it's statistically less than 1% of people after each of the vaccines, around 1% or slightly less, need to have medical attention. The other index of severity is how did it impact on their routine daily activities, dose 1, 2, or 3, as we're discussing. And we see that about 10 to 20% of people have found severe enough that they had to modify what they were doing, couldn't do their normal activities. And the demographics are also displayed. So each of the representative groups are displayed in in the AUSVAC safety. So now we come to the ATAGI updates for the last few weeks, or since we last did an update ourselves in a session like this. And so there are new groups that have been added to the previously defined winter booster doses. And there's a handy chart that you can have on your desk to be able to summarize that. But we're going to step through it and look in a little more detail. So in the end of April, the recommendations for a booster dose for COVID vaccine included all individuals over 16 years of age for a single booster dose recommended for those who completed their primary course more than 3 months ago. And that would be either with Pfizer or Moderna, either of the two mRNA vaccines, preferred for that booster dose in people aged 18 and over. And for those 16 and over, just the Pfizer vaccine should be used. And those brands, are for use regardless of what the primary course vaccine brand was. Those who are severely immunocompromised, AstraZeneca is no longer recommended as a booster dose, even when there are no contraindications, but it still can be used for the purpose in people who have had a significant reaction to the mRNA vaccines. So AstraZeneca could be used as a booster dose then, but there's no requirement for people who've already received a booster dose of AstraZeneca to have another mRNA vaccine until they're due for their subsequent dose beyond that. The only scenario where the booster dose with an AstraZeneca is actively recommended is for people with medical contraindication to the Pfizer or Moderna vaccine from previous vaccine. So Novavax has been provisionally approved by the TGA for use as a primary course, but it's much more limited in data existing on the safety and immunogenicity as a booster dose. So it's not TGA registered for that indication. ATAGI advised that it can be used as a booster dose in someone 18 or older if no other vaccine brand is suitable for that individual. So it's better for them to have Novavax than no vaccine at all, but it's not on current recommendations of preferred vaccine. So severely immunocompromised individuals 16 and over who have received a third dose are also recommended to receive another booster dose called the winter booster 3 months after their third primary dose, in line with the timing for general population. So this is for people who qualified for 3 doses as a primary course. And so those 3 doses, none of them are considered a booster dose. It's this extra one for them that is considered the booster dose. And that 3-month interval is in line with the other first booster doses. Pregnant women and adolescents over 16 who have received primary course more than 3 months ago recommended to receive a booster dose. And an additional booster dose to increase vaccine protection before winter is for most people a 4th dose, or for severely immunocompromised people, it's actually their 5th dose. The winter dose can be given 4 months after the first booster dose. Also, the recommendation that the COVID vaccine should be deferred for at least 3 months following a confirmed COVID infection for all COVID-19 vaccine doses, including booster doses. So 3-month interval now. The definition of the booster doses and eligibility it can be confusing. So let's clarify it as we've just said. A booster dose refers to the additional vaccine dose after the primary vaccine course. So for most people, a 2-dose primary course, then the booster dose is their 3rd. But for people with severe immunocompromise, their primary course is 3 doses. So their first booster dose is actually their 4th dose. Mixed schedules are also included in the definition. So when we define doses, we're not talking about dose 1, 2, or 3 of a particular brand. We're talking about COVID-19 dose 1, 2, or 3 when we're totaling them. There is this box 1 table in the guidelines from ATAGI defining who are the people who have immunocompromised conditions for which a 3rd primary dose is recommended, and therefore the winter booster dose was recommended, and it defined the levels of various immunosuppressive medications. So this is the chart that needed to be referred to. So then we had last week the expansion of the TAGI recommendations for the winter COVID-19 booster dose for people at increased risk of severe COVID-19, extending beyond those that were previously defined just as severely immunocompromised. So that came out a week, or nearly 2 weeks ago now, and that is the expanded ATAGI recommendations for the winter booster dose, extending beyond what existed before. So where the current situation, as we described before, has been extended to include additional winter booster dose to be given 4 months after the first booster dose for anybody aged 16 to 64 who has a medical condition that increases their risk of severe COVID illness, and we'll look at the table of that in a moment, and people with disability with significant or complex health needs or multiple comorbidities which increase their risk of poor outcome from COVID. Just to clarify, healthy people aged 16 to 64 who do not have one of the risk factors that we're about to look at are not recommended to receive an additional winter booster dose at this time, as their risk of severe illness after the first booster dose is likely to remain low if they get COVID. And that includes healthy people from occupational groups such as healthcare workers. That is not yet recommended unless they fit the group we're about to talk about. Pregnant women who've not have an additional risk factor for severe disease, who have received their 3 doses, are not currently recommended for a winter booster dose unless they themselves have one of these. And as we mentioned a minute ago, if an individual's received a confirmed, who has had a confirmed COVID infection, they should delay their winter booster dose for 3 months. Those are the vaccines, that is the Comirnaty or the Spikevax are the preferred vaccines for COVID booster doses, but AstraZeneca, we just mentioned before, is only indicated for a booster dose where an mRNA vaccine is contraindicated or where they decline vaccination, and Novavax could be used in someone 18 and over. So on this note, ATAGI took the opportunity to recommend and encourage people to be vaccinated against flu, and we'll cover that in a few minutes when we get up to flu. But if they're not yet eligible for their additional booster COVID vaccine, they should proceed and have a flu vaccine without waiting. So here is the recommended group that was released last week. That to extend from the existing group who we defined before, the additional group are people aged 16 to 64 with complex chronic or severe conditions that increase their risk, and that is coming on our slide. So here is that that summary table so that you can see the conditions that people have that make them eligible now where they weren't before, age 16 to 64, including such things as diabetes that require medication to control their diabetes. These are people with cancer that might be non-hematological, so expanding from the group before. Chronic inflammatory conditions that weren't previously included, and chronic lung disease as mentioned there, and so on. So including severe obesity as well as severe underweight. So this chart is the one that should be on your wall or at the fingertips on your desktop. That's just to dissect them out in detail, which I think is self-explanatory from the chart that you'll see, and you can check the disease off as you see them. But this little phrase here gives clinical latitude. People in these groups are likely to have ongoing increased risk of severe COVID even after primary vaccination, and the examples listed here are not exhaustive, and providers may include individuals with conditions similar to these below based on clinical judgment. So this is not a proscriptive list. That's just the top part of it, of course. That's the rest of it to fit on the one slide. And you can see these are much more typical of what we consider to be people with conditions where we'd expect severe outcome. There was also, just to remind you of the guidance that came out in February from ATAGI of the acute major medical conditions that warrant temporary medical exemption. And what's changed is that the rapid antigen tests were considered acceptable proof of infection, and the time frame for people for temporary deferral was reduced from 6 months to 4 months. So that is people who were considered they wanted to delay the vaccination, where 6 months existed before was reduced to 4 months. And the recommendation in general is that people wait 3 months after the vaccination. So that brings us up to date for COVID-19. Let's dive into the flu program. And just to give a picture, here we are with the national figures updated for the end of May, and the Immunisation Coalition pooled data for 2022 shows in heavy red here where we're at right now. And you can see this high swing up in the last month that we've experienced. And just to compare to the previous years, so 2020 was a 0 year for flu, almost non-existent. Case numbers Australia-wide for the whole year in the hundreds, and not a single death rate. I think only one hospitalisation. Extraordinary. And 2001 is indistinguishable from that. The numbers are a little bit higher, but the perspective, as you can see, 2 years of no flu, followed by this year, which was 2019, which the area under the graph is the highest number of cases we've ever had in a year. That's over 300,000 confirmed cases of flu in 2019. And between 2019 and the other big year, 2017, was this year, 2018, in green. And that was a very low year that followed what was the highest ever recorded season at the time, and that was over 250,000 confirmed cases. So we had the typical swing where we get surge years following quiet years. That's why this year is such a fear for us. If we've never had, unprecedented to have 2 years without any flu, and we're not sure that this isn't going to be a twindemic, and it's shaping up at the moment to be twindemic of flu epidemic as well as COVID pandemic. So the latest Victorian figures, just to give you a hint, it's still early in the season and hard to identify, and it's not really meaningful. Don't get too scared by the cases being 200 times higher than what we had in 2021, because we had almost zero in 2021. But it is marginally higher than the number we saw in the other highest year to date of 2019. Almost all the cases that we're seeing are type A, H3N2, and almost no Bs or H1N1s at the moment. The flu, the numbers will build and the meaningfulness of it will do, but we can see increasing numbers of flu and COVID numbers in huge proportions at the moment. 70,000 cases a week in Victoria, and this is the national chart. No, this is a Victorian chart looking at the seasonal, usual season. The high peak we saw in end of 2017, the winter of 2017. 2018, a very low season. 2019, a very high, and that's a big, large area under the curve in total numbers. And then 2020, 2021, nothing. And then 2022, we're already seeing this. So where this is heading, this is earlier than usual and higher for this time of year. Just to reflect on the COVID numbers and the proportions, this is the COVID second wave. The first wave doesn't even rate. Second wave barely rates, and this is our wave of COVID. So we're seeing what looks like twindemic developing. The reports are all in here, updated fortnightly in the VicSpin reports, and we're seeing here influenza-like illness consultations in black is the current season. Looking up, these wobble around a bit, so this number will change as we move to the next month. But in terms of looking at the numbers of people reporting flu-like illness, which could be flu, COVID, or any of the other viral respiratory illnesses, we're seeing a higher level, higher even than we've seen back in 2019. The proportion of cases that are laboratory confirmed flu, so influenza A H3 is in the green here. COVID numbers are, these are isolates of small, relatively small numbers of detections because we're fairly early in the season, but the perspective of it is that we're seeing a higher percentage in this black line of flu positivity, and we're seeing the cases coming through. Interestingly, no RSV yet detected in Victoria and low numbers around Australia, and we're not sure what that means. RSV may not be gone, but it's been displaced by COVID. And you can watch these reports as they become available. This is just showing the strain breakdown and the predominance of H3 and 2. All of these charts are visible. In terms of safety, let's look at the AUSVAC safety for flu vaccines. And this is a type of breakdown in the annual report from 2020, but we saw in 2021 not a huge numbers of cases to be able to compared to previous years, but our current figures are showing a growing number, 66,000 cases reported as of a couple of weeks ago, that are not cases reported, sorry, these are cases that participate in the vaccine safety data. So that's quite a high percentage of the cases of flu at the time. And like we saw with COVID, you can break down and see a pie graph of how many people experienced an adverse event to a flu vaccine. And you can break these down by ages, and I'll just show you a snippet of what they look like. Children aged under 5, to date, 2,500 people have participated in the survey, and about 20% have experienced one of these adverse events. And in terms of severity, we see that less than close to 0.5% of people have any of children under 5, this is have reaction to the flu vaccine that needed medical attention, and only 4% had to modify their behaviour. These are children under 5, so it's a representative. With children 5 years and older with standard vaccines, so not the 65 and over, but we see a similar proportion of about 20% of this sample size experiencing this type of reaction, and also a tiny percentage that had medical need for medical attention. So and a similar proportion impacted on routine activities. The data is also there for 60 years and older. 60 years, 65, everybody over 65 has had an adjuvanted vaccine. People over 60 may have had a high-dose vaccine. So this data is just of those who received either adjuvanted or high-dose vaccine. So it's not everybody 60 to 64, only those who made access to the high-dose vaccine, but it includes everybody 65. This data represents everybody 65 and over who participated in the safety reporting. And so you can see under 20% of people reacted and 2% had any significant impact on their activities. Pregnant women, also very important to track, fairly low numbers, but still a similar proportion, similar perspective in terms of impact. And Indigenous people, also important to track to see if there's any difference from in severity that they would experience compared to non-Indigenous, and we're seeing a similar proportion across that. So we looked last time at our seminar, and I won't step through it in detail, but the ATAGI recommendations for flu vaccination for 2022 and the importance of the different vaccines. There are 8 different vaccines licensed and available across the different ages, and we looked at that in detail last time, bearing in mind that the high-dose vaccine is now licensed for people 60 and over, but the flu and the Fluad Quad is only a recommended licensed and free for everybody over 65, whereas people over 60 can access a private vaccine. This is not included in the expanded flu program that we'll look at in a minute. Flucelvax Quad is a cell-based vaccine, and that is a new direction that flu vaccines are taking, and we'll talk about that another time. The other vaccines are the standard dose vaccines that are available, and the chart shows which age they're licensed for, and what was funded or is funded under the National Immunisation Program, but was the baseline that we came at before yesterday's announcement of the expansion in Victoria, which we'll come to in a sec. So these are the slides that we looked at last time when we did a specific flu update, and in the interest of time, we're just going to skip through these for the minute. The eligibility is what exists under the NIP, and it's important that we still keep a track, you'll see in a minute, of who gets a national immunisation program funded vaccine compared to a Victorian program which started today. So the medical conditions that make people eligible between 5 and 65 for a national immunisation funded program are those. And let's now dive in and have a look where that's been expanded. So yesterday, the Minister for Health in Victoria reported the Victorian program. And I have to point out the program is slightly different in each state in terms of some elements of it. So this is a Victorian detail. It's outlined on the website, and I encourage you to, if you haven't already looked at, to examine the two important elements of what the Victorian program provides only for people who were not otherwise funded under the other. So it's 5 to 64 years of age. That is Victorian government reimbursing practices for $25 per flu vaccine for those eligible people. Plus the second part of this program is a $2,000 grant to practices and pharmacies who are interested to expand their capacity. So there's two prongs to this. One is the reimbursement of the cost of the private vaccine that we've already purchased and have in our fridges, plus a grant to enable us to extend our capacity. So it's available and encouraged to all Victorian GPs and pharmacies who need to register by the 10th of June. There's only a 4-day window to register because registration will only open 6th of June. And the registration needs to be completed in those 4 days to participate. So the grant and the program will support us to deliver those vaccines, and offering free vaccines to the public will help boost the vaccination coverage. So who's eligible? It's basically anybody who is not already covered under the NIP. And we need to track those doses so that we get the correct reimbursement from the government and not under reimbursed. So in general practice, GPs can claim $25 reimbursement for the flu vaccine administered for non-NIP eligible flu vaccines administered only in the month of June. This is so it started today. The program starts. We don't apply for the grant until 6th of June, but we start accumulating our tracking sheet of people who we've given a vaccine for. We don't sell them, we give it to them free, and we are reimbursed by the government at the end of the month. Naturally, any Medicare benefit payment that exists continues to apply. There's no compulsion necessarily to bulk bill to provide the service, but that depends on how your service is structured, and of course patients need to agree. People who are not eligible for Medicare can still receive this Victorian funded vaccine at no cost at a community pharmacy. But GPs can't charge patients for the cost of the flu vaccine because it's being reimbursed by the Victorian government. So what that means is that people who are not eligible for Medicare can receive the funded vaccine at a pharmacy, but we can't charge patients without a Medicare card for the cost of the flu vaccine. I believe we can give the vaccine and charge them a private fee if they're agreeable to do it. But in pharmacies, because of the way they're funded, it is they will be able to claim under the same program for vaccines given in the month of June in a similar way, but they're not entitled to MBS billing and therefore being reimbursed for the cost of administration of both the NIP and non-NIP vaccine. So there's no administration costs at the point of care for Victorians getting their vaccine at the pharmacy, whether it's NIP or non-NIP. So they should not charge an administration fee to any person receiving flu vaccine. The timing of reimbursements, it will only occur as a single payment at the conclusion of the program after providers have submitted the evidence of the total number of de-identified flu vaccines administered through the program, and the online portal will be available with submission fields that need to be done. The grants of the $2,000 are available to support GPs and pharmacies, and the grants need to satisfy these criteria for the month of June to be able to administer a minimum of 50 flu vaccines in addition to what they're normally giving, plus a minimum of 8 additional practitioner working hours or 8 additional vaccine clinic hours, and they have to be in addition to the usual practitioner hours that are existing. De-identified records need to be kept, and the grant of the one-off payment of $2,000 per site for those that are eligible, apply, and are granted it will apply. Owners of multiple clinics have provision. Timing of payments is a single payment at the end of the program, and registration must be between these dates. So the key dates: 1st of June, it's commenced today. 6th to 10th of June, the application for the grant program. 30th of June, the final day, and on the 1st to 15th of July is the reporting period where practices will supply lists for reimbursement of vaccine doses given, and those who have grants will be provided the outcome points that need to. The practical upshot is that we, in general practice and pharmacies, will continue to order private vaccines as our usual processes. We are using, for this extended program, existing private vaccines for which we will be reimbursed. We don't use NIP vaccines for those people. So that's why it's still important to track and monitor people eligible for NIP-funded vaccine and to use the NIP a source for that. And for the extended program, we don't use the NIP-funded vaccine, we use our private vaccine. What could be simpler? Let's have a little look at timing of administration of COVID vaccines with others, as it's a very common question asked. COVID-19 vaccines can generally be co-administered with flu vaccine. Studies demonstrate the safety and immunogenicity of the co-administration, and they can be also co-administered with other vaccines if required. Let's just tease that out a little bit. It does include routine childhood and adolescent vaccines, and the benefit of ensuring timely vaccination and maintaining high vaccine uptake at accessible points and periods is far outweigh any potential risk of immunogenicity interference or local adverse reactions or fever. But having said that, there is recognised still that it's limited evidence on both the safety and the effectiveness of co-administering them, COVID vaccines with other vaccines. So it is a bit of a balance and a discretion about whether there is a need to co-administer the vaccine or whether it's better to separate. So just an awareness that is the priority here to give the vaccines together, because otherwise we're not going to have an opportunity to give they may delay or miss the second vaccine. Or is the priority we don't want this person who's had perhaps significant reactions in the past to have higher reaction rate, which is certainly the potential when more than one vaccine is given together. So whichever the priority is, clinical judgment will dictate, but they can be given together. The trade-off is giving them together, you get better timeliness and lower risk of missing doses, but a slightly higher risk of safety and effectiveness because data's not there. The other common one we're asked for co-administration is zoster vaccine on the same day as other vaccines, COVID or otherwise. And the advice, which we're going to look at in detail a little bit further when we get up to that part, is both Shingrix and Zostavax can be given with most other live and inactivated vaccines, but at different injection sites. However, be aware of the following precautions: that there is limited evidence on giving either Zostavax or Shingrix with a COVID-19 vaccine. So whilst co-administration can occur if required, like we said on the previous slide, providers need to balance that need for co-administration with the potential for higher adverse events, where these vaccines already are more reactogenic. COVID vaccines and shingles vaccines are generally more reactogenic than most others. So there is an increase in this risk of mild to moderate adverse events. So Zostavax can be administered with other live vaccines, but remember in the principle of live vaccines being close together, if they're not given on the same days, they do need to be deferred by a 4-week interval. That is between 2 different live vaccines. That interval doesn't exist with live and non-live, or of course 2 non-live vaccines. So specifically, Shingrix and Fluad Quad can be given on the same day if necessary, but to be aware of the lack of high-level data for the safety and efficacy of it. So if there is no burning need to give them together, then separating them perhaps by a week is worthwhile. The other tricky management issue is managing multiple vaccines within the general practice. And that not just do we manage multiple vaccines, but there's even multiple COVID vaccines to deal with. And that can be tricky if you're running a clinic with more than one COVID vaccine. So in principle, multiple vaccines, where if a child's receiving multiple vaccines at the one time, we try to give the most painful vaccine last. Notoriously, pneumococcal conjugate vaccine is more painful to give than the other routine childhood vaccines, and giving that last may help reduce the unpleasant experience of the worst one first, followed by the others that will be feared more than they would otherwise need. Naturally, the recording the specific location of each separate injection so that any reaction can be identified, and the site of administration for children under 12 months of age should be either in the anterolateral thigh, which is the preferred site, or some people have experience and have personal preference to have in the ventrogluteal area, which I won't emphasize, as I think the anterolateral thigh is by far the most preferred from recipient and person administering. If a child needs multiple vaccines at the same visit, the options are 2 injections in the same thigh, separated by at least 2.5 centimeters, and the option is to give 1 injection into each anterolateral thigh and 1 into each ventrogluteal area, but only if the person is experienced in giving into the ventrogluteal area, obviously. So 4 vaccines can be given by 2 in each side of the anterolateral thigh. Older children with larger muscle bulk, obviously from 12 months of age and onwards, a single injection can be given into each deltoid muscle. But if a child with small deltoid size needs multiple vaccines, then if the deltoid mass is large enough, you can give 2 injections into that side, separated by 2.5 centimeters. But if you don't have enough room in a small deltoid, then to use the thighs for the additional doses. The cuddle or straddle position can provide access to multiple limbs during a single encounter, and there are extenuating circumstances where giving more than 2 in the one deltoid may be warranted if a person has particular individual issues that need to be given. There has been discussion of simultaneous injections, and the handbook mentions two immunisation providers giving injections at the same time. The evidence is not sufficient enough to have a recommendation that one way is better than the other. It can be an intimidating and a scary experience in some individuals, or it can be a way of relieving, cutting the time of it and giving greater support in others. So really, it's discussed as a technique that could be considered, but it wouldn't necessarily be preferred, nor is it suggested that it's preferred to be given over one at a time. So then we have the issue that's of administering the vaccines, but in managing the vaccines themselves, we've got the added task and challenge of having multiple COVID vaccines that can be given at the one time. So this very handy A3 poster was recently updated, and so if you haven't got the latest version, then it's important that we do it. This was updated on the 9th of May, so if you've got a previous version, just make sure you update it. Make sure you've got the updated version. At a glance, it looks the same. There are just some small details about the timing of what we mentioned earlier. So just looking on the front of the double-sided poster is at the top half, the primary course, all the different COVID vaccines that exist and how they're distinguished, the different approved ages and the dose volumes and doses per vial, the recommended intervals, and these have been modified in the last month or two, where the recommended intervals have been modified, and the provision for primary course intervals for exceptions to be provided. And it's important to have this chart by your fingertips so that you can glance at that and remember where the third dose and subsequent doses. The lower half of the page on the front covers the storage temperatures and the recommendations for transport, and all the footnotes to explain the top page. Over the page are the booster doses. The top half, again, describing the vaccines, COVID vaccines licensed for booster and their age group indications and their dilutions required, and the dosage intervals revised for the latest guidelines, and the winter dose defined and updated for the latest guidelines. So that chart is the handy one to have. The bottom half of the booster page, obviously, the storage and the footnotes. So that chart is really important to have available so that you're managing multiple COVID vaccines. Your practice might, like our nurses in our practice, wanted to give a summary sheet for a handy guide in addition to what was before, because we're only handing in our clinic Pfizer vaccine, but we wanted to make sure that the doses and ages of the different Pfizer vaccine recommendations are easy to follow and handy. So by all means, if you wish to make an individual customized chart to suit your purposes, that's a very important tool to have. Just a little look at the COVID safety data that exists for the different vaccines that we haven't already covered in the COVID and the flu. So the safety report from 2020 is the most complete, but you can see live updated. Most of the updates are done about 3 monthly, and they cover all of the participating sites that are growing all the time, with a SMS text message sent to vaccine recipients 3 days after their vaccine, and they receive a very quick response, or we receive back very quick response that Ausvac Safety collate, and we've got very huge increasing numbers of sites, and you saw the numbers of people participating. What you get online when you have a look at the reports, you'll see for each time point, here are the early childhood, 2, 4, and 6 months, you get a pie chart to describe how many people did not have any reaction, those who did, those who required medical attention, the nature of the reactions, and the schedule of vaccines included in this report, and the numbers of people reporting in that time period. And at 4 months, similar, and at 6 months, similar. So those charts are really handy to help guide you. Adolescents or older children, adolescents, older children first, 12 months, 18 months, and 4 years of age are each represented in a report that you can generate. And adolescents and younger and older adolescents for the vaccines that are represented in their schedule time points, and for pregnant women also to be able to track the adverse reaction rate for flu and for DTP for them. So the HPV vaccine and the DTP for that age, the meningococcal ACYW in this age, and as I said, flu and DTP vaccines. As well as that, the older adults for pneumococcal conjugate vaccine for age 70 above, and the Zostavax being the NIP vaccine is also reported, but Shingrix is not reported as it's not an NIP vaccine. So the Zoster vaccine showing here is just Zostavax. And seasonal flu, we looked at the breakdown on all of those. Just want to conclude in the next few minutes before we open to question time. Shingles vaccine update, because there has been some information change since we did a whole session on it last year. So the changes have caused a release of an ATAGI update just 2 weeks ago, and NCIRS fact sheet has come out just in the last, sorry, this is 6 weeks ago, and this is 2 weeks ago, and this is the NCIRS. So this is 5 pages of a ATAGI update that NCIRS have said, we want to provide a tool that will help explain these 5 pages, and they've produced a 17-page guide as well as a 10-page frequently asked question. So there's a lot of information there, and it's important you have the tool that is going to help you to understand the changes and the important practical questions when you're dealing with the patient in front of you. And it's really important for the reasons I'm about to say. So firstly, just to look through the NCIRS fact sheet, we'll use the ATAGI one as a summary. That's how I think it's best used. So this 17-page fact sheet, 3/4 of that, a quarter of that is actually references. So it's about 12 pages of information. It includes a list of the additional resources that one would use to support your recommendations for shingles prevention with vaccine, including the fact sheet I just referred to, the ATAGI statement that we referred to, and of course the immunisation handbook online, the TGA product information for Shingrix and also for Zostavax, and the chickenpox vaccine for Australian children. The reason for all of this emphasis is because of the rare but serious risk of disseminated varicella zoster virus infection from Zostavax vaccine in people who are significantly immunocompromised. And that has resulted in 3 deaths in Australia since the commencement of the Zostavax program. So there is an alternative vaccine in Shingrix, and so all of these guidelines are to help guide us in giving safe and advice for the important prevention of serious shingles illness, which is such an important illness in Australia because of its incidence and severity. So Zostavax specifically is contraindicated in people with current or recent severe immunocompromising conditions, and a careful pre-screening and risk-based assessments required before administration of any dose of a Zostavax vaccine. So it's the one time where we would say better to delay and be sure that this vaccine is safe to give, rather than to think I'd better give the vaccine, it's probably going to be okay, and I mightn't get them back for the to finish the vaccination. Here is the caution, and that caution is important. There's guidance also on anybody who does experience disseminated vesicular rash within the month following vaccine administration with Zostavax, who is unwell after it. So just to remind you, the beginning of the guide does remind us how shingles is such an important disease, usually self-limiting, but can lead into serious postherpetic neuralgia. And it's an age incidence. That is, the older one is, the higher the chance of developing shingles in the lifetime. And most becomes significant over the age of 50. And the older a person is, not only are they more likely to get shingles, but they're also more likely to get complications such as postherpetic neuralgia and other serious related conditions. There are now 2 vaccines available, so it's not quite 12 months that Shingrix has been available. It's approaching that. Zostavax has been around for a number of years and has been available and licensed for people over 50 and funded for people over 70. Shingrix is an adjuvanted vaccine, not live, and it is given in a 2-dose schedule, not a 1-dose. And the period is 2 to 6 months apart, and it's now available for people aged over 18 who are at high risk of serious outcome from shingles illness, that is generally immunocompromised, anybody over 18. So who should be vaccinated? Well, unless they're contraindicated, all immunocompetent people over 50 and any immunocompromised person from 18 are now recommended to receive vaccination to prevent shingles and its complications. And this is new from when we did the update last year. So the recommendation came out at the end of the year, and its awareness is fairly low. That's why we're emphasising it now. People previously vaccinated with Zostavax can receive Shingrix if they wish to increase their protection, because we also recognise that the duration of protection of Zostavax vaccine actually wanes after just a few years and falls to about half its level by 5 years and onwards. The optimum age to receive vaccination of shingles vaccine depends on the patient's age and immune status and the duration of protection and the individual's desire to protect themselves from the disease. So in deciding which vaccine to use, Shingrix is preferred over Zostavax, according to ATAGI and NCIRS, for prevention of Zoster illness and its complications in people over 50, because it is significantly more efficacious. However, Shingrix has to be privately prescribed because it is not available on the National Immunisation Program for anybody, and the cost is significant. Around $270 a dose, and 2 doses are required. Private health insurance with extras does provide a small rebate of somewhere around $40 a dose, depending on the fund, can be higher than that, but only for people with extras. So Zostavax is readily available and effective only for immunocompetent people aged 50 and above who have no contraindication. It's NIP funded for people aged 70 with a catch-up program of age 70 to 71 that was extended last year in October for a further 12 months from then. So further 12 months from the end of this year. So it was extended by 2 years. And October next year it will conclude, unless they extend it again. But Shingrix is the only available vaccine for immunocompromised people aged 18 to 49 years of age. And so Zostavax can't be given under 50 years of age. In people aged 50 or more who are immunocompromised, Zostavax is generally contraindicated, so Shingrix should be used. Now, Zostavax may be considered for use in people with mild immunocompromise, and so this is the grey area. In this situation, Zostavax should only be administered after careful assessment of the degree of immunocompromise using the tool that exists. And I'll show you the tool that exists in a minute, because it's not a simple tool, but only where that tool has been applied should anyone proceed to give a Zostavax vaccine to someone even with mild immunocompromise. Very rarely, the disseminated chickenpox type rash appears after a few weeks after receipt of Zostavax, and those people who are given Zostavax should be advised to be alert for that so that they can get assessed as to whether the safety of that. To emphasize contraindications to Zostavax vaccine is generally contraindicated in people who are immunocompromised due to disease or medication, and Shingrix should only be the one offered to that population. Pregnant women should not receive Zostavax. It's a live vaccine, and there's currently no data on the use of Shingrix in pregnant women, so that pregnancy should not receive shingles vaccination at the moment. Naturally, people with anaphylaxis to a zoster vaccine or a component of it within Zostavax or Shingrix shouldn't be vaccinated with that respective vaccine, but potentially could be given the other vaccine if they've not got that. So in guidance, what should you consider when offering a zoster vaccine? It's important for anybody over the, even though both vaccines could be given potentially to, either vaccine could be given to people 50 years and older. Age-related risk is significant. So the older a person is, the higher the risk. And if people get to 80 years of age and they've got about a 50% chance of getting shingles in their remaining lifetime. The likelihood of complications such as PHN is starkly related to age as well. Higher the risk from higher age. The duration of protection by the vaccine chosen. So Shingrix has both a higher vaccine efficacy, over 90% at any age group, higher for people aged 50 to 70, but even 70 and above, around 90% effective plus. And the protection may persist to 10 years with just a small reduction, even for elderly people, from somewhere around 90 to 85%. The studies formally have reported to 7 years, and elements of them have gone on to 10. But the effectiveness of Zostavax appears to wane more quickly, significantly reducing by 5 to 10 years after vaccination. And that's from a lower level of protection to start with that is also age-related. The older they are when they have this Zostavax vaccine, the lower the level of expected efficacy. And it's from that point that the waning occurs. So it's possible that a person vaccinated at a younger age, in their 50s or 60s, may have reduced protection as they get older from a Zostavax vaccine that doesn't seem to apply with Shingrix. So booster doses of either are not currently recommended based on a lack of data, but we'll see what evolves into the future. The immune status is the other important determinant. So people who are immunocompromised, obviously we wouldn't want to offer them a zoster vaccine, but there's nothing to prevent household contacts of unvaccinated immunocompromised people having a zoster vaccine of either one to help reduce the, their risk. Remember, shingles is caught from yourself, not so much from a person next to you, unless you've had bone marrow transplant, for example, and your immunity is wiped, in which case you would be at risk of getting chickenpox infection from a household member of who has a shingles lesion. Individuals who desire to protect themselves from disease and cost are the other factors to bear into mind when offering zoster vaccine. And cost, remember, should not be judgmental by the vaccine provider. It's our role to inform people of what their options, including risks and costs are, and we should not presume that a person who is in a low socioeconomic position would not afford a vaccine, and therefore we wouldn't offer it to them. They will assess cost as part of the equation of value, and if they value the vaccine highly, they will be prepared to purchase the cost, like car tyres, protecting safety. And that's their choice, not the provider to judge them. The recommendations for use of Zostavax are outlined in the handbook, of course, and it's important to remember the purpose for all of this concern is that already 3 people have died from disseminated infection following Zostavax, 2 who clearly fit the definition of severely immunocompromised, but 1 who actually had a mild immunocompromised state where the recommendations did not contraindicate vaccination, and they still had a reaction. So it's very, very important. We talked before about Shingrix vaccine being given co-administered with other vaccines, and of course, it's we heard that it can be given, but it depends on the context because the data is not high. So just to conclude my talk before we open up to questions, just a summary of all of that from the ATAGI take on the shingles vaccines. Zostavax is one, Shingrix is the other. Zostavax is single dose, registered for use only from age 50 and above, and contraindicated in immunocompromised people. Shingrix is recommended as a 2-dose schedule, interval of 2 to 6 months. It's registered for use from people 50 and over in immunocompetent adults, and from 18 and over for immunocompromised individuals. And in those immunocompromised adults from 18, the shorter interval of 1 to 2 months between the 2 doses is acceptable in individuals who are currently or expected to be immunocompromised. Remember, though, that nobody is funded under the NIP for a Shingrix vaccine, even people who are immunocompromised over the age of 18 who are recommended and can only access that vaccine for protection against shingles, they're not funded to have a free NIP vaccine. In those aged 50 and above, Shingrix is preferred over Zostavax for prevention of shingles and its complications of shingles due to its higher efficacy of the Shingrix vaccine compared to Zostavax, but only available in private prescription. Therefore, in immunocompetent adults over 50, Zostavax is the vaccine, is readily available and an alternative vaccine to reduce the risk, but it is not the preferred vaccine. It is the only one funded for people aged 70 to 79. In immunocompromised adults aged 18 to 49, only Shingrix is available for them. And immunocompromised adults over 50 years of age, Zostavax is contraindicated, so Shingrix. So there is the summary table that ATAGI have provided to put that on a chart that you can have at your fingertips. And all of that we've just discussed in detail, and you can see that the provisos and stars and footnotes are listed. So the thing we didn't mention yet is what I referred to before, the shingles screening for contraindications. And there are a couple of tools. The handbook provides the following chart for potential vaccine recipients to fill out and for vaccine providers to check before they are given a shingles vaccine. So they're asked the basic questions, and they'll answer the questions for the provider to then provide an assessment. And I'll show you the answers to those in a moment. So this helps determine our decision process for recommending one vaccine or the other. The outcome is that we will decide from that whether there is no contraindication to a Zoster vaccine, and if the person has the choice of Zostavax or Shingrix, we can provide it. Or if Zostavax is contraindicated, then obviously it can't. where Zostavax should be delayed, and where they have a temporary delay condition, or whether their level of immunocompromise is uncertain and not to vaccinate at this time. So that they provide the notes for healthcare providers to help guide how you respond to the answers they give along the lines of all of what I've mentioned just before. Rather than repeating it, just show you that it is displayed there for your reference and handy guide, and it will help you decide in everything about identifying whether they have a risk. But there is one more element to it, and that is, it's one thing to know about the immunocompromising conditions. They are defined here, but the immunosuppressant therapy can't fit on a single page. So the next page, I'm going to show you the table of how to identify immunosuppressive therapy and what doses of what immunosuppressive therapy contraindicate. So you can't see any detail there because the page is too long. I'm going to expand it and break it down into two. So the table shows the type of immunosuppressive therapy, whether it's corticosteroid and what doses are safe to vaccinate and what doses the vaccine's contraindicated, and the acceptable timing of Zostavax if the dose is contraindicated with a temporary delay. Then there are the DMARDs and the different types of DMARDs. That are listed with doses that are considered safe to vaccinate and doses that are not. And that's just half the page. The second half of the page includes other DMARDs not listed above, as well as other T-cell inhibitors and other similar medications. Denosumab is clarified that there's no evidence for significant immunosuppression, so it's one that can, for which it's not contraindicated to give Zostavax. Other unspecified immunosuppressants are in terms of timing, and other tumor necrotic factor agents that are mentioned, as well as hematopoietic stem cell transplant and what's required for separating. So you can see why it's so complicated, why the risk exists that if we don't take the time, well, number one, if we're not aware to look for it, and number two, if we don't take the time. Melbourne Vaccination Education Centre, in collaboration with SafeVic, have done a 3-page summary of all that, and you're welcome to use this as an alternative guide. And it's got 2 pages of guidance and a 1-page chart, and that could be used if you prefer, or the handbook. Those are just 2 alternative guides for the tool of the important role of assessing safety to give a Zostavax vaccine. So thanks so much for your attention. I think we've got time for a few questions now, Caroline.
Thanks so much, Peter. Some wonderful information there, and another fantastic presentation from you once again. Is Shingrix still given 12 months from an infection with shingles, or does it not matter as it's not live?
So yes, it does matter, and it's a very good question. The fine print of those charts that I mentioned does, and the NCIRS and the ATAGI guide do mention that. So thanks for bringing that up. I didn't. 12 months is recommended between either any shingles vaccine following an episode of shingles illness. So 12-month interval from the illness to when either Zostavax or Shingrix is given. And that same period, 12 months, is currently recommended between having a Zostavax and a Shingrix vaccine following. So if a person wishes to have Shingrix, then that would be interval of 12 months after the Zostavax. I don't think there's any indication to give the reverse. Giving a Zostavax after a Shingrix vaccine is I don't know of any indication why you do it, because if they've only had one Shingrix in the first case, they'd want a second Shingrix, and if they've had 2 Shingrixes, they don't need any more, and the Zostavax is not going to provide necessarily any protection. That's the current advice.
Okay, great. Thank you. Is it necessary or desirable to determine whether a patient has had chickenpox prior to considering whether Shingrix is worthwhile?
That's a very good question, and certainly that might be relevant when well, with healthcare workers. It can also be relevant for immunocompromised people before you're assessing how they are. But generally, we don't require serology to be done before providing or recommending shingles vaccines. So it's assumed that every adult over the age of 30 will have been exposed to varicella zoster virus, whether they've had a known chickenpox infection or not. So almost everybody has immunity following previous exposure, even if they didn't have a known illness, because it's so prevalent, so infectious, and you can have subclinical chickenpox infection and not know. But if you've identified, say on serology that was done, if you've identified that the person is not has got no antibodies, no protective levels of antibodies to varicella zoster virus, then they would ideally be given a chickenpox vaccine, varicella vaccine, rather than a shingles vaccine. So neither shingles vaccines is licensed or recommended to use for primary vaccination for non-immune uh, um, varicella zoster people. I hope that
Great.
clarified that.
Thank you so much, Peter. So on behalf of Murray PHN, thank you, Peter, for providing us with this update tonight. We greatly appreciate your time. Before we conclude, I'd like to highlight additional resources on Murray Health Pathways. If you do not already have a login, access can be requested via the website displayed on the screen. Health Pathways is a free web-based portal available for use by clinicians at the point of care to access evidence-based, locally accessible patient pathways. More than 650 pathways have been localised for the Murray PHN region with input from more than 100 health professionals. We value your feedback about the education provided today. Please complete the survey by scanning the QR code displayed on the screen or using the link provided in your chat box. Your feedback will be used for planning and improvement. The survey link will also be emailed to attendees after the webinar if you are unable to complete it now. For upcoming webinars, please check the events calendar on our website or subscribe to the Murray PHN Events Update. Thank you once again, Peter, for your presentation tonight, and thank you all for attending. Enjoy the rest of your evening.